Hello and welcome to Chronic Pain Tips for Patients, a podcast created to help people living with chronic pain better understand their condition, their treatment options, and the questions they should ask before making decisions about their care. My name is Yuri Martins. I'm a chronic pain physician in the St. Louis and Southern Illinois area, and today we're going to talk about interlaminar epidural steroid injections. This is a common procedure in pain medicine, but the name can sound a little bit intimidating. So, in this episode, we will slow down and explain what it means, what it may be recommended, what kinds of pain it is designed to treat, what actually happens during the procedure, what benefits patients can realistically expect, and what risks and complications patients should understand before giving consent. We'll also talk about the difference between cervical, thoracic, lumbar, and caudal epidural injections, and why it is so important to tell your doctor about blood thinners if you have diabetes, infections, allergies, and prior reactions to injections. As always, my idea of this podcast is for education only. It does not replace medical advice from your own physician or qualified healthcare professional. Your anatomy, medical history, imaging findings, medications, and risks may be different from someone else's. So, when would a pain doctor recommend an epidural steroid injection? Neck pain and low back pain are common, but pain that travels into an arm or leg often tells a different story. When pain begins in the spine and radiates along the path of a nerve, doctors often call it radicular pain. If it starts in the neck, it may travel into the shoulder, arm, or hand. If it starts in the low back, it may travel into the buttock, thighs, calf, and foot. Many patients know lower back related radiating leg pain as sciatica. This distinction matters because epidural steroid injections are not meant for every kind of neck or back pain. They are most commonly considered when pain is thought to come from irritation, inflammation, or compression of a spinal nerve root. A spinal nerve root can become irritated for several reasons. A disc herniation, sometimes called a disc bulge, is one of the classic examples. The discs are cushion like structures between the bones of the spine. When part of a disc pushes out of place, it can narrow the space around the nerve and cause pain that travels down an arm or a leg. Other causes include spinal stenosis, arthritis, bone spurs, degenerative disc disease, or scar tissue after surgery. The important idea is that radicular pain is not simply muscle pain or joint pain in the neck or back. It reflects irritation of a nerve root itself. A compressed nerve root can become swollen and chemically inflamed. Disc material, inflammatory chemicals, and mechanical pressure can make the nerve more sensitive. That is why a patient may feel burning, shooting, electric, tingling, or radiating pain far away from the spine, even though the irritated nerve begins in the neck or low back. Sometimes radicular pain may also be associated with numbness, weakness, or changes in reflexes. So, what is an epidural steroid injection? An epidural steroid injection is a procedure designed to deliver anti-inflammatory medication into the epidural space. The epidural space is located inside the spine, but outside the sac that contains the spinal cord, spinal fluid, and nerves. The word steroid refers to a corticosteroid medication. This is not the same as the anabolic steroids sometimes associated with bodybuilding. In this setting, corticosteroids are used to reduce inflammation. The goal is to place the goal is to place medication close to the irritated spinal nerves. The injection does not repair a herniated disc. It does not remove arthritis. It does not permanently open a narrow spinal canal. Instead, the goal is to reduce inflammation around the nerve, decrease nerve sensitivity, and when successful, reduce the arm or leg pain enough to improve function, sleep, walking tolerance, and participation in physical therapy. For many patients, injections are not the first treatment. Initial care may include activity modification, physical therapy, anti-inflammatory medications, nerve pain medications, and other conservative treatments. If those options do not help enough, are not tolerated, or symptoms are significantly limiting function, an epidural steroid injection may be discussed. What does interlaminar mean? There are several ways to perform epidural steroid injections. The most common approaches are interlaminar, transforaminal, or caudal. Today, we are focusing mainly on the interlaminar approach. In an interlaminar epidural steroid injection, the physician places the needle from the back of the spine between two nearby bones called lamina into the epidural space. Usually, contrast dye is injected under X-ray guidance to confirm that the medication will spread within the epidural space. Then, the steroid medication, often mixed with local anesthetic or normal saline, is injected. The interlaminar approach can allow medication to spread across a broader region of the epidural space. This may be useful when pain is central, bilateral, or related to inflammation affecting more than one nerve area. Your physician chooses the approach based on your symptoms, physical examination, imaging studies, anatomy, prior surgery, risks, and the suspected source of pain. Cervical, thoracic, and lumbar injections are not the same. The word epidural does not describe one single procedure or one single risk profile. A lumbar interlaminar epidural steroid injection is performed in the lower back. This is the region commonly involved in sciatica, lumbar disc herniation, and lumbar spinal stenosis. In the lumbar region, the spinal cord itself has usually ended, and the nerve roots continue downward as the cauda equina. This does not make the procedure risk-free, but the anatomy is different from the neck and mid-back. A cervical interlaminar epidural steroid injection is performed in the neck. This requires particular care because the spinal cord is present, the epidural space is narrower, and important blood vessels are nearby. For that reason, cervical epidural injections are often considered higher risk than lumbar epidural injections, even though serious complications remain rare when performed carefully and with appropriate imaging guidance. A thoracic interlaminar epidural steroid injection is performed in the mid-back. Thoracic epidural injections are less common than cervical or lumbar injections. They also require special attention because the spinal cord is present in this region and the anatomy can be narrow. Another way to perform an epidural steroid injection is called a caudal epidural. The word caudal means toward the tailbone. Instead of placing the needle between the bones of the lumbar spine, the caudal approach enters the epidural space through a small opening near the bottom of the sacrum, close to the tailbone. This opening is called the sacral hiatus. In simple terms, both caudal and interlaminar epidural injections try to deliver medication into the epidural space. They simply enter the space from different locations. With an interlaminar injection, the needle enters between two vertebral levels in the spine, usually closer to the suspected level of nerve irritation. With a caudal epidural injection, the needle enters much lower, through the sacral hiatus, at the bottom of the spine, and the medication travels upward inside the epidural space towards the irritated nerves. That difference matters because the caudal injection starts farther away from the usual lumbar pain generator. It often requires a large volume of medication to spread upwards. Caudal injections commonly use about 10 to 20 cc's of medication, while interlaminar injections often use a smaller volume, commonly around 5 to 10 mLs. The caudal approach may spread medications over multiple The caudal approach may spread medication over multiple levels, but it's usually less specific than an interlaminar injection directed closer to the suspected problem. The caudal approach is often considered technically simpler and, in some ways, safer than other epidural routes, especially in the lumbar spine. One reason is that the needle enters far below where the spinal cord usually ends. In most adults, the spinal cord ends around the upper lumbar spine, more specifically at the L2 level, while the caudal injection enters near the sacral canal. This means there is essentially no risk of directly injuring the spinal cord with the caudal needle placement itself. The risk of puncturing the dura, which is the membrane that contains spinal fluid, is also generally lower with the caudal approach. In a typical patient, the dural sac ends around the S2 level, while the sacral hiatus is lower, often around the S4 or S5 level. That creates a larger safety margin compared with an interlaminar injection, where the needle is placed closer to the dural sac. But safer doesn't mean risk-free. A caudal epidural injection still involves a needle, medication, contrast dye, and entry into the epidural space. Possible complications include bleeding, infection, intravascular injection, allergic reaction, increased pain, and steroid-related risks. The caudal approach also has unique technical risks, such as injection into the wrong tissue plane, injection into sacral bone marrow, or extremely rare, injury to nearby structures, such as the rectum if the needle is directed incorrectly. Because the injection site is closer to the perianal region, infection control and sterile technique are especially important. For interlaminar epidural injections, the safety concern related to particulate embolization is generally considered lower than with transforaminal injections, because the needle is not intentionally positioned near to foraminal arteries. Particulate steroids may still be used in interlaminar approaches depending on physician preference, patient factors, and institutional practice. A reasonable principle is to use the lowest effective steroid dose and avoid unnecessary repeat exposure. So, how often can epidural steroid injections be repeated? This depends on the patient, diagnosis, response, and risks. Many clinicians limit epidural steroid injections to around 3 to 4 per year in a given region of the spine. This is not because a fifth injection suddenly becomes dangerous for everyone, but because repeated corticosteroid exposure can increase the risk of systemic complications. In addition, health insurers, including Medicare, often will not pay for interlaminar epidural injections done in the same area more frequently than every 3 months. Many insurers also request documentation of at least 50% pain relief for at least 3 months to approve a repeat injection. Unfortunately, health insurers are dictating care more frequently in the chronic pain area. If the first injection does not help at all, repeating the same repeating the same injection may not make sense unless there is a clear reason to adjust the approach, level, medication, or diagnosis. If the first injection gives partial but meaningful relief, a repeat injection may be considered. In some patients, several injections can extend the period of improvement, but the decision should be individualized. The question should not be, how many injections am I allowed to have? The better question is, what are we trying to accomplish with this injection? And how will we decide whether it was successful? So, which questions should patients ask before the procedure? Before agreeing to an epidural steroid injection, it's reasonable to ask yourself whether you understand the answer to several important questions. What diagnosis are we treating? Does my pain pattern match a pinched or inflamed nerve? What did my MRI or CT show? Why are you recommending this approach instead of another approach? Which spinal level will you target? Will fluoroscopy and contrast be used? What medication will be injected? Do I need to stop any blood thinners, and who will coordinate that plan? What are the risks in my specific case? How do my diabetes, blood pressure, osteoporosis, infection risk, pregnancy status, or other medical conditions affect the decision? These questions are not confrontational, they are appropriate. Good pain care should be collaborative, and you should understand your disease and the treatment being offered to you. So, what is the bottom line? Interlaminar epidural steroid injections can be a useful tool for selected patients with neck, mid-back, or low back pain caused by inflamed or irritated spinal nerves. They may reduce pain traveling into the arms or legs, improve function, and make it easier to participate in physical therapy and daily activities. But they are not magic. They do not repair a disc herniation. They do not erase arthritis. They do not guarantee that surgery will be avoided. Their benefit is usually temporary, often lasting weeks to a few months, though some patients have longer relief. They are generally safe when performed by experienced clinicians using appropriate image guidance, but they do carry risks. Most complications are minor and temporary. Serious complications are rare, but they can occur. You must tell your pain doctor about blood thinners, diabetes, infections, allergies, prior spine surgery, pregnancy, and any previous reaction to injections. A good procedure is not just about placing a needle. It is about choosing the right patient, the right target, the right technique, and the right plan. The goal is not simply to perform a procedure. The goal is to reduce pain, improve function, support rehabilitation, and help patients make informed decisions about their care. Thank you for listening to Chronic Pain Tips for Patients. My goal is to help you understand your pain, ask better questions, and feel more prepared when discussing treatment options with your healthcare team. As always, this is not medical advice. You should always consult a pain doctor to have a personalized plan for your chronic pain care.